And now we are going to discuss the people who want to be with us. Please welcome. And please, if we can see the video from Isabel.
See many things. You will see the different range of adduction abduction of the right vocal fold compared to the left. You will see the different position of the arytenoids, and you also see the supraglottic asymmetry, more supraglottic contraction in this right side. And you will notice too the difficulty on do the falsetto, a great contraction, anterior-posterior supraglottic contraction in the falsetto voice. A lot of tension in the falsetto that he previously
so we can take away the, okay, thank you. Thank you. Well, I don't know if John is still there. If somebody wants to comment about this this video, John was interested, but I don't see him. Otherwise, yes, Peter, you want to say? Peter Huli?
Maybe Ron. No, I would like ask a question. What was the treatment in this case? It's very good seen. It could be very good, very well seen that there is an abduction problem and also an adduction problem. But how was the treatment for this guy?
So the first thing is to explain to him that he probably will be out of the professional singing during 3 months at least. So this was the first thing, because he was really very stressed because he had this previous diagnosis and the treatment didn't work. So the first thing I think it was very good for him is to explain to him that this is a neurogenic lesion and this will take time to recover. And the only treatment was speech singing therapy. So we recommend to work on the falsetto, to work on the glissando, and to try to work with the cricothyroid muscle to force the falsetto and the upper register. And that was all. The voice therapy.
Yes, and Iris Rodriguez is asking, how many sessions per week did this patient make?
Yes.
2 sessions a week.
Okay.
Yes, this is
6 months.
This is great because,
no, 6 months was the average was 6 months, but when I saw him, he was already 3 months from the beginning of the symptoms. So the treatment was 3 months.
Okay,
in total, the recovery from the injury to from the moment he felt the injury to the recovering was 6 months.
Okay, thank you, Isabel.
Yes, Carmen.
Hi to all. It's very nice to see you all. Thank you, Isabel. I just want to say I understand the question that John Rubit had, because you can see that the arytenoid is pushed forward. I'm sure you had a shock when you saw it was the superior laryngeal nerve, the one that was injured, because, you know, I would have thought that it was the recurrent big time. Was it not the case for you?
You know, the symptoms of the patient with this loss of the high register was more the initial suspicion with the history was the superior laryngeal nerve, because he always had a very easy falsetto and he has lost the falsetto. So the initial suspicion was, but yeah, it's true that this forward of the arytenoid, I think that or my interpretation is that perhaps the elongation of the vocal fold that is not made because of the lesion of the superior laryngeal nerve, perhaps the elongation is not only from the forward part of the vocal folds, but also this shorter vocal fold is also can be also endoscopic sign of a superior laryngeal nerve lesion. Endoscopic signs of superior laryngeal nerve lesions are also confused sometimes. We are not very, at least me, I don't have a really strong images to suspect clearly a superior laryngeal nerve lesion. It's more sometimes the symptoms, but not the endoscopic findings.
Yeah, that's true, because sometimes they say the larynx moves to one side, and in other articles they say it moves to the other one, so it's definitely not clear. It's quite a challenge, yes.
Yes, well, what I think is also that there are many subtle changes in many of the artistic singing voice activities. For example, I was interested in if they're only exercising, I don't know, also in staccato.
Do you mean for the recovery of the?
Yes,
That is that exercises, but the main object to recover, because in the chest voice and low, middle, and in the center of the voice and the low part of the voice, he had no problems. So the voice was perfect, very resonant, and very, it was really normal. So the challenge was this upper register, that is the main part that was worked.
And also sometimes in this kind of neurogenic lesions, I don't know if you are also considering this, they use gabapentin, or they use also complex B and also glutathione, because they are trying to recover all the functions of the nerve. I don't know if you have some experience with this kind of treatments, Isabel.
I usually don't use many of these drugs. I have tried sometimes with gabapentin in some cases, but I don't have really a great experience with these drugs. But gabapentin is sometimes not very well tolerated because of central effects, and I don't use it routinely. I don't know if anybody has experience in
yes, and
this.
what I think also is a very great thing that the singer and the actors, they know their function during normal singing or acting, because there are many singers that come to the medical examination with stroboscopy or acoustical analysis, but only when they are sick. And for example, sometimes immobilities because of not proper vocal exercises or singing problem, they are not in a perfect situation. So, and Lisa wanted to say something. Lisa?
Hello. Oh, I wanted to say something for.
Yes, Lisa, please.
I'm for Filipa's paper.
Yes. Hi, Lisa. How are you?
I have a question.
But please let me give the word to Peter. Peter, you wanted to say something about Isabel?
Yeah, I wanted to ask one question because of one of my patients. He's a 40 years old baritone soloist, and he has problem with his voice, and he had paralysis of the recurrent nerve of one side. So it's an idiopathic problem, and he came to me not because of this problem, but it was a diagnosis I had to find, and it's very interesting because he's number patient for about 10 years, and he has still this recurrent nerve paralysis of the left vocal fold, and he's still singing. as baritone oratories and also lieder abende, and it's very strange for me. He has sometimes problems, and he's sometimes he has a kind of thickening of vocal fold, but the one side is completely without movement. So he's 40 years old, and I'm thinking about the future for him, and his problems get he comes very frequently now, and I don't know how to proceed with him, because an augmentation, I think, will not have this effect, and what to do with him. We do these voice treatments, logopedic treatment, and so on, but how to continue?
Yes, Isabel, you want to add something?
Yeah, I think we are always afraid to do surgery on professional singers if they are singing. So my perception is that singers have a very good control of their voices, and they have a very good compensation with when they have lesions. We sometimes see lesions and they can still singing. I don't know. It's a very difficult patient, very difficult case to decide to do an augmentation.
Maybe I can send you some one piece of his video and maybe audio file.
Sure.
Maybe you are able to yeah to
Oh,
give
yes.
me any recommendation.
I wanted to tell you about an interactive section in our CoMeT webpage where we can send videos and things like that. And also, I remember in Frankfurt with Catherine Newman, Professor Ishiki presented a case. I don't know if you're familiar with this case. A tenor from Japan. He had a left vocal cord complete paralysis because of a recurrent lesion. And after 2 years of surgery plus singing lessons plus rehabilitation, he could sing again opera. And it is a wonderful case. I shall ask Professor Ishiki if we can put that on the webpage because it's very interesting. And in Frankfurt, in this Congress of Collegium Medicorum Theatri, the singer came to us and he sang to us, and it was wonderful to hear that. Okay, so let's go to Philippa. Like, yes, Ron?
Yeah, on this topic here, obviously it depends a lot on where the affected vocal fold is sitting, but also as it deteriorates over time. One of the most important aspects is the contour of the medial edge for different pitches. And so I would assume that as this problem gets worse, he may have to shift keys of certain songs so that the higher notes are not as demanding because the key is shifted, if that's possible. But the augmentation has to be really kind of tricky in order to keep the contour right and mucosa wave relatively symmetric. You could have some asymmetric wave if the glottal flow is giving the right acoustics. But the control, it's actually interesting if he has a kind of a full range now, because that it really means he's keeping the contours about right. But as atrophy continues, really smart laying out, and depending on where the augmentation would occur, more medially or more laterally, shaping that contour will be really quite critical.
And apropos this problem of augmentation, I would suggest only to make augmentation through fat, not through other artificial substance, because as we know, hyaluronic acid and also hydroxyapatite, they have had problems now. So fat is very important for singer, not the other substances. I don't know if somebody wants to comment more. Yes, Ilter, about this case.
I have been using the fascia lata injection for 4 years, for the last 4 years. And I have to say that I quit it all of other injection materials since then, and I'm so happy. Maybe you can consider this for the next operations, but it is consistent. No side effects I haven't seen because it's autolog, and it stays there.
What's the material?
Fascia,
The
it's
fascia
fascia.
lata.
But you make in the vestibule, and of course, fat you can put it in the middle of the vocal fold. I don't know.
Yes, of course,
Yes.
but just lateral to the vocal cord, vocal ligament, you can also inject fascia lata because it's autolog and it converges with the tissues in the muscle.
Yes, and you can push it a
So
little.
the body elasticity does not change as in calcium hydroxyapatite or in silicone prosthesis, because it changes the elasticity of the body, the vibrating body. But the fascia here doesn't make that much change. And if you inject the material to the correct places in the vocal fold and reshape it during the operation with a blunt instrument, I'm so happy with this.
And I think, talking about the surgery, the best surgery would be indirect surgery with stroboscopy. Then you can see all the muscle, how it's working during the surgery. So it is real interesting things. I don't know, Andrea, if you have some comment about this, Andrea Richimakarin.
Hear me? Can you hear me?
Yes, we hear you very, very low.
Yeah. Oh, very.
You have to shout.
Okay. As you know, we use centrifuge fat, and we are very happy of it because it's a very soft tissue, and it has stem cells inside that gives this graft a long life. Is not a temporary tissue for us. Is our preferred material fat centrifuged fat, not only fat.
Oh, this is great.
Has anyone
Somebody has another comment, Peter?
Has anyone experience with these augmentations of fat, for example, or fascia lata, without general anesthesia? So in
Yes,
indirect.
I have this. Yes, I
fact,
make all the surgeries with indirect
Under
approach.
local, yes, under local.
And also Andrea, I think, no?
Under local, of course, under
local anesthesia with sedation, with IV.
I have to say, always in general anesthesia, because under local anesthesia, there are some advantages that you can go on or stop somewhere, but you cannot reshape the injected material by massaging on the vocal fold. So I think it's a great advantage. Of course, the fascia lata, taking the fascia lata and preparing it, I would prefer if I were the patient under general anesthesia, because you know, it's a surgical operation. It can be done, but I always prefer when I'm doing fascia lata, I always prefer general anesthesia.
Yeah, the advantage of indirect phonosurgery with local anesthesia is that, of course, you have to have time and patience, but during stroboscopy, you can also reshape that, but slowly. Of course, under general anesthesia, you can see a wonderful shape, but you don't have the function. That's why I prefer to have the function as to have only the steady vocal fold, because if you are accustomed to make the surgery and the injection during local anesthesia with function, it's a little bit different. Of course, I agree, but I do prefer indirect phonosurgery.
Yeah.
And you,
May
Peter,
I
wanted
add
to say
something about the function?
Mhm.
When I palpate, I mean, with the instrumental palpation of the vocal fold, I can imagine what kind of a vibration the mucosa and the body, I mean, the body and the cover. So you can feel different parts, the stiffness of the body in different parts during palpation. So then you can reshape the distribution of the injected material, and so it becomes mostly balanced in the distribution of the material becomes mostly balanced, and so it is an answer. But of course, looking at the vocal fold vibrating during the injection is, of course, has the advantage I have mentioned.
Yes, yes, I agree with you that it is, of course, the laryngologists and phonosurgeons, we have a lot of experience by palpation. But in my experience doing indirect surgery for 30 years, I think the function during the surgery helps a lot. And I don't know, Peter, you wanted to say something?
And which kind of syringe do you use? Because you need a high pressure for the fat. And what?
Yes.
How does it work? How do you ever get a pistol? And how in sedation? You told me. You told us. Which kind of sedation?
This is a great question for me, especially because for the fascia lata, it should be high pressure syringe. So it's not so easy to put the syringe into the larynx during giving a high pressure during local anesthesia. But in general anesthesia, high pressure control is better.
But I had a question to Eugenia. How
Yes.
does she do it? Yeah. How does it
Yes,
work with the high pressure?
I also use microfrance syringe, and also I make some of the needles, of the big needles, in order to put fat. I don't have experience with fascia lata, but I shall begin later through your comment. I have experience with fat, and sometimes we put fat not only in the vestibule but also, as said, in the middle vocal fold part, and we have good results. Also.
The patient stand it through the mouth with
Yes,
the high
yes,
pressure.
yes. Of course, we have the anesthetist make a sedation, intra IV sedation, and then we have the local anesthesia from the lips until the larynx, as I learned by Professor Wendler and Professor Steiner. And it is, I am very happy with that. Of course, it's difficult for the surgeon, and it's difficult also for the time of the surgery. But because the patient is awake, you don't have any cannula or anything bother you. So you can see pianissimo, you can see fortissimo during surgery, and of course all the register, and you can also make the glissandi during the surgery, and this is a great advantage. Sometimes it is not the right tone because of the sedation, but it helps a lot. And talking about the next, I don't know, Andrea, if you want to add something, because you are working with both
Yes,
methods,
I
indirect
agree.
and direct.
I perfectly agree with you, Eugenia. We also use a high pressure pistol by Mectronics under local. As you know, we use our technique through the nose with the fiberscope, and we are very happy about this technique because we have the control of the patient's voice and the anatomy of the larynx during the intervention.
Thank you. And I make it through mouth, not through nose. And I use shorts and Wolf endoscopes, 90 and 70 degrees, with normal light and also with stroboscopical light. And so, talking about the next presentation from menopause, you wanted to ask something, Lisa?
No, me no. Me
No,
not.
no, Liza.
Philip, a wonderful presentation. I'm interested to know,
Can you speak, please, a little louder?
can you hear me better now? I can also
Yes.
closer. And I have a mic here, so let me use this mic. So my question is about the use or the research with traditional hormone replacement versus the newer bioidentical hormone replacement, which I've personally been doing for 15 years. And 15 years ago, it was considered quite radical and not well known, except on the West Coast and the East Coast, Los Angeles and New York City. And the difference, the main difference, was that in bioidentical hormone replacement, it brings on a monthly period again, indefinitely. And it has estradiol day 1 through 30, and progesterone is added day 15 to 30. So and the levels take a woman back to her premenopausal, so in her mid 40s. And it requires, every 3 months, it requires blood tests to check on the levels of the dosages are correct or need to be changed. And it's becoming a more popular method here in the US. And I'm curious to know if this method, there are several, by the way, there are several protocols in the US. The one I started was the Schwarzbein protocol, which has since changed. And then there was a different protocol called the Wiley protocol that was very controversial. And that took a woman back to her high estrogen levels of her mid-20s. Some women had great results, some women had terrible results. And so I'm sure there's many other protocols, but the one I continue to do, and I'm 65 now, is the progesterone added day 15 to 30. So just curious, what's happening around the world in regarding this?
Well, I'm afraid I don't have very good news for you. First, we still don't understand the effects of menopause on the voice because the studies that I have shown, primary studies that used in this meta-analysis, showed that the diversity of methods of data collection and data analysis, even sometimes for things like basic acoustic measures. Second, we cannot expect that the effects of sex steroid hormones, in this case the absence of estrogens, or not the absence but the decrease, can be measured just by acoustic parameters. I think we are just looking at the top of the tip of the iceberg, and there's much more information on voice source analysis that should be done to really understand the impacts of menopause on how the voice changes. Also, with respect to hormonal replacement therapy, there's so much diversity in the studies that have been published, in the drugs that they use, the dosages that they use, that I don't have a clear answer to you. So I think this is a very poorly studied field, if we must say. Somebody has commented about the relationship between vaginal mucosa and larynx mucosa. I can say that the skin is also a target organ of sex hormones, and the skin elasticity and collagen content changes so much during the menopause that maybe we are disregarding that and it will be beautiful to have a study that compares the skin elasticity of different types of mucosas elsewhere in the body, and what happens with the voice, because maybe we can discover non-invasive methods of assessing the pliability of the vocal folds by studying other organs. And I would like to take the advantage that they gave me the microphone to say that, for example, in Spain, there has been published now an article on the newspaper talking about a software that can discover COVID by voice. And that software, I don't know, I didn't read it yet, but I believe that despite if this study was well done or not, or if the metrics were well analyzed or not, that for sure the vocal folds response to hormones is also reflected in other sex target organs in the body, and we should be looking more carefully in that area. What I'm interested now, Lisa, is not so much about the hormonal replacement therapy, but the natural menopause, because also there seems to be a quite difference in the effects of menopause on the voice if a woman has a high body mass index as compared to low body mass index. So the way we metabolize estrogens in fat tissue, for example, it's akin to the effects on the voice being milder than if we don't have that fat tissue. So it's the same as the wrinkles, as you know. So I think this is a huge area of research that needs much interdisciplinarity, and I hope I will try that to bring some light into the area.
Yes, thank you. And I also think that we cannot forget all the circle from the different hormones, like, for example, thyroid, and also about this recording or test with sound or voice to diagnose COVID. I was telling my opinion that it was not possible to make a pathognomonic test for COVID through the voice, because for me is we have to be very careful, because everybody wants to use acoustical analysis to make a diagnosis. But if we look in the clinical atmosphere, that we have many viral and bacterial infections that can change the resonance or can change the emission of the voice, and of course can change the pulmonary and pressure, glottal pressure index. So we cannot say this is only COVID. So for me, it's like not a really serious situation. It would be wonderful to have a pathognomonic format for COVID, but I mean, we are dealing with a sickness of 10 months. We cannot have through the voice and through the sound, because we don't have any particular pathognomonic situation. And so I think as a voice specialist, we have to take care of that. Yes, Orieta?
Yeah.
I do agree with you. I first reply to you and then have a question for Philippa. Just anecdotically, now that you know that in Scala course we had some troubles with COVID last month, and what is just anecdotal is that indeed I listen to my female choristers, and some of them were showing just a phone call, so I would not assure that just the weaker voice, and they do not realize that. That was curious to me, because they were weaker on their high pitches, but no, I'm fine. I've not my there's no difference in my voice. So I
will try to understand. I can't say anything more. I think that the softwares based on voice recognition, like for Parkinson's or so, are in emergency room choices, because they try to understand which pneumonia might be and which one we must be more careful about. So it's a long way to understand COVID indeed. But with Philippa and Lisa, I should say that in next studies about menopause, or in your beautiful research about menopause, Philippa, we should also distinguish participants between female that have, even in their younger ages, troubles with menses in their voices, and some other may breastfeed and be on stage with no problems at all. So maybe I would like to understand if these people, yes, if these people will have a better or worse menopause.
There is some data, but it's based on perceptions of people in an interview. There is a nice PhD thesis by Katie Price that interviewed many women, and one of the questions was exactly the severity of PMS symptoms as with relationship with afterward effects of menopause. But the thing is that the tests that she did was not statistical tests of association. She just compared the percentage of people that responded yes to PMS and the percentage of people that responded to severe menopause, and therefore you cannot see if there is a relation, because that's not the case. You cannot relate percentages and take conclusions from that. But yes, there is a possibility for that, for sure. But what I wanted to say is that indeed, as I responded to Ron, it is very difficult, but it will be very important to have of course, a longitudinal study that could follow up a female voice user within 3 years' time, because that has not been done in the literature. So the literature has just shown comparative studies of different women, and also I think, as I said, it is important to look at the mobility of the vocal folds, because, for example, in a case study that I have with pregnancy that showed that the mobility was quite different with different stages of pregnancy, and therefore in the menopause, if there is this loss of estrogens and therefore the receptors that are free can connect to testosterone, then there will be for sure an effect of that on the way you use the vocal folds. That cannot be necessarily translated into voice metrics, acoustic voice metrics like fundamental frequency. And so this is to say that we have to stop doing research in voice that looks at one comfortable tone, sustain that tone with an A vowel, and that's it. We have our study done. That doesn't tell anything about the voice, and we should be looking at the voice as a pneumologist looks at the lungs, is an x-ray of the whole picture. So maybe voice maps, phonetograms, or things like that would be more recommendable to study the effects of treatments, of different hormones, and so forth.
And also what I think it is very important in the clinical daily life, that we have to support the singers and actresses in order to change the humidity, to avoid as much as possible the change of resonance through the different lack of flexibility. And of course, the vocalizations and the singing voice lessons, they have to keep on, because as we know, the muscles have to keep on working properly. And many of the patients, they have a lot of fear about the menopause and the postmenopause. So we have to deal with that and to keep on researching. And I would like to say hello to Alejandro Armenta. He's a wonderful baritone, and he will take part on the interactive section because he's a baritone. and he has been patient from Peter Hulin, Karin Jusen, and me. So we will talk in this section about his case, not now. But anyway, welcome, Alejandro, and we love to hear you sometime. And also, I would say to the wonderful presentation of the olfactory and taste functions, if you want to ask something to Rita, please.
Yes, I'm very sensitive to smells. And once I had to sing in a competition and I sang terrible because I was a student and I didn't have much money. Well, and I had to go to a hotel and the room stank smoke. And this really, really affected me. So thank you for bringing that. And if you have any comments about my experience, that was awful.
I don't know if somebody has another comment before Orieta answer Filipa. No? And thank you also, Pedro. Pedro away. I imagine this is Pedro Pestana. Okay, Orieta.
Well, Philippa, you're not alone at all, because there is at least one famous soloist, female soloist, which obliged all of us to use no perfume, because this was it was not a case of allergy, but just something that was unbalancing her. And the same problem we had in again in our choristers, because one of them, if male, choose a perfume, and two or three of them, the nearest, were very disturbed. Something almost like chemical reactions. So I think that anyway, we are accustomed to feel a good perfume around us and feel happy. But if you are singing or just humming something and you smell a very disgusting thing, it may be difficult to go on. And in the same way, people losing their smell nowadays, some have some sort of parosmia or even cacosmia, and keep on your profession while you have always something stinking, not in your hotel room, but in your nose, inside you. And when you are breathing and trying to sing, maybe you difficult. So it's a new thing we must cope with.
And is there differences between genders, the sexes, I mean? Do you
As
think
far as now,
females, because for example, there is these studies about the senses and sexual attractiveness, and that males find female voices more attractive during ovulation, which by the way, I don't believe, but anyway, and also that the sense of smell is different according to the phases of the cycle of a woman, or for example, in a man, in relation to a man, the smells that the men have. So that's why my question, if there is differences between sexes.
well, we are smelling the leading male. So, as far as now, there's a huge consortium got some 50,000 answers, and they are trying to understand, also because they come from many different cultures, from many different situations. And they also made a free self-check and home test, because the best way to get out seems the olfactory training. So they have the way to let people find in their own home, wherever they are, from asafoetida to basil to and things that you may have and use. Because it's useless, I say, that you must find out the lavender essential oil that way, that if you are not allowed to get out your home first. And then we have a lot, indeed, many female are answering, but we are not, we are just trying to understand if this might be a bias, because people working with computer, people in lockdown, people curious about questionnaires, a survey or another one, maybe that in female there is a instinctive curiosity about smell, about taste, while even if many males are a chef or work a lot with gastronomy and kitchen, but do not many times they are confident on themselves, and so they say, oh, I have a good taste and there's no trouble with me. So it's a curious bias, but that's why I think that the more people we have, the more consistent results may be. There are already two, and the third article is publishing now from the ZCR, so I will let you know something, but we are still looking at the Everest, but we are in the base camp.
Thank you, Marietta. Unfortunately, the last phrase is so clear because of the internet connection, but thank you very much. And well, we cannot forget that rhinencephalo is the oldest in the ontogenic scale. That's why we have the animal parts, as Filipa said and Marietta said.
Yes.
I don't know, Erki, if you have some experience about your menopause and to comment something about that, Erki? Erki? The connection is not very stable. Somebody wants to say something else, or shall we see next Saturday, please?
I
don't
think
forget.
Ron wanted to say something.
Yes?
Well, you may have just mentioned it, Eugenia, I'm not sure. But when I was singing in choruses, when the guy next to me had a bad body odor, I was pretty upset. So is body odor one of the primary aspects to be studying? I kind of missed some of the conversation maybe about that. Marietta?
And yes, the body is important also because Bach and Axel themselves won the Nobel Prize about the perception of body that the newborn has of his mother's body. So we must remember that if when we are here, I think also many of us to stay in a Zoom meeting, we use something, we wash, we can't stay here if we have a bad smell about us, on us. So if I have someone near me smelling bad is not good. A social distance comes in the moment. In a moment, but the problem is that people losing their smell are not free to understand and not able to understand if I have a proper hygiene, or I'm exceeding my perfume, or I stink, I do not perceive that. It's very disorienting because you are not, and also they do not realize the smell of their relatives. And some of them claim, well, I have a grandchild now, but I can't smell the odor of a new baby, and it's very disorienting. We do not realize smell and taste for us until we lost it.
I think one of the best Christmas gifts that you can give a relative is a bar of soap.
Yes. Yes, and for example, one thing that happens sometimes is that many very low level respiratory allergies that the singer or actor, they do not know about that. They have this hyper reactivity to the others and of course to the taste. And sometimes it changes the biofeedback during singing or acting. So this is not so easy to deal with, because there are senses that they do not have so many neurodevelopment receptors in the central nervous system also. Yes, Orieta?
Yes, the problem is also about expectation. We have in our brain somewhere I must smell this, and in some other places we have expectations, and if we can't perceive that, or we have a distorted perception, it's not so easy. So the sensescape around us is important, even if we do not realize. We always think of our visual surroundings, or maybe our auditory surroundings, but it's much more. We have some sort of sphere around us that must be as we expect that, and losing something creates some sort of disruption in the balance. And we can't realize why, but many times I think that also in this pandemic, people's claiming about tinnitus announcements or vertigo or so, maybe that one receptors helps the other ones, and if I do not have all the metrics, all the orchestra working together, I think that the show is not on, and I can't understand why.
Yes, but I think this is one of the, let's say, small advantages from pandemia, is that we take care of also this such that we say small senses, because this I think, and I was very interested in some of your slides that I will study afterwards, Orieta, because I think the emotional part of the singers and actors are also related to all these small senses, as you say. And of course, as we have been chatting now about the book, The Perfume, that we know there are many conscious things that come properly from the small senses, the neurovegetative senses as well. No? And well, I want to thank you all. I don't know if somebody has another comment. And Arturito, hello. I didn't say hello to you. Arturito Jonathan is also with us. And well, our dear Alejandro Armenta, unfortunately he had COVID, but he's going to talk about that in the interactive section, because he lost the smell and the taste for a while. I hope he recovers very soon. Somebody wants to say something else to the presentations, and I think it's wonderful to have this discussion after the session, to the persons who allowed us to keep talking about these themes without any time border. And Ron, is all the time great thing to see you, Erki, Ilter, Orieta, Carmen, and Annabelle, Carolina, Pedro, Rocio, Fatima, Arturito, that you joined with us. And of course, our dear presenters, Isabel Garcia Lopez, Filipa La, and Orieta Calcinoni. And I love you all. Many dear kisses from Mexico. And please, I see you next Saturday. Don't forget, if you cannot be with us, send something that we can put on the video. Bravo, Collegium Medicorum Theatri.